Lawrence, sitting next to you is the Vice President of the South African Society of Anesthesiologists. Okay, did I pronounce that right? Okay.
Anesthesiologist.
Okay.
But we know what it means.
Yeah. So, Lawrence, first of all, I noticed that you're not on Twitter at all, which concerns me because probably most of the time you're sitting there with the patient sleeping. And maybe you should put some of your
waiting for
thoughts.
that to be added to our anesthetic machines.
Okay, so I'm going to ask you exactly the same question that I asked. What is your sense? So there's probably one paragraph in total in NHI about specialists and hospital groups. And what's your feeling about the NHI and its impact on specialists?
So I'd like to also just quickly talk to the cost and taxes and things like that. I think that it's important to understand that the tax credit to the fiscus is around 20 billion rand, but it may be far less because a lot of the people who could claim on the lowest end who might fall off if the tax credits fall away may not claim because they don't know they can. Just in terms of the cost of NHI, I think it's important to consider, if we don't know what the cost is, where else can we look? The minister speaks to other OECD countries. I think it's important to understand that in Japan, there's a very high level of interpersonal trust. That's why they're such a rich economy. They don't have natural resource. And it's arguable whether we have the same level or even close. That being said, I don't think that we can't engage through collaboration, innovation, and leadership. In terms of the cost, just to give some numbers to everyone here, the cost of healthcare in the United States, which was cited, is north of $9,500 per capita for the population, and their access is poor if they're not funded. No access. Here we have access. In fact, our access isn't bad in terms of WHO criteria. Most NHS environments, Canada, Australia, the UK, and Scandinavian countries, cost between $3,500 and $5,500 per capita. That's what it costs for those countries to run healthcare. Brazil costs around $1,000 per capita. South Africa, I've last interrogated the numbers, is at around $600 per capita, public and private. If we split them out, and we'd say, how much do the 8.8 million lives assured pay for private healthcare in this country? It's $1,600 per capita. There may be a bit more in terms of some out-of-pocket payments, but there's a lot of assumptions that I think we can deal with another time. I just think it's important to understand. And then in the public sector, we're looking at about $380 per capita. So what will it cost? If we want quality at an NHS-type environment, can we achieve $1,600 per capita? And the answer is probably not. But it does this does talk to how do we collaborate with all the stakeholders responsibly, with less emotion perhaps, to achieve true healthcare. Talking to what the sentiment and feeling is amongst specialists. In the NHI, you're right, there's very little in terms of particular for specialists. The devil for me is in the detail of the NHI, and I've really spent a lot of time looking through it. And there are serious concerns, and I'm happy to share those if we have time. But in terms of a healthcare practitioner myself, the most important thing for most practitioners, believe it or not, is actually patient care first. When we've done surveys of our own membership, where we got over 65% participation, which I think is quite phenomenal, the number one reason for either leaving the country or leaving the public sector or staying in a sector or returning to the public sector was ability to ply your trade properly to patient care. Remuneration usually was third or fourth criterion. So I think that's one of the big threats. In other words, can we make sure that patient care is good? I left the public sector principally. At the time I left, the salaries were really poor, and I can share that with you, but principally because I felt what medical practitioners sometimes call moral injury. I couldn't treat patients how I knew they needed to be treated. So that's the first thing, and we can talk to why people leave the private sector and the public sector. But in terms of what I'm seeing today, since the NHI has been published, is not a question of practitioners coming to us through many disciplines and saying, how am I going to get money? How am I going to earn a living? It is, I'm not sure that I can negotiate my ability to not have healthcare for myself and my family. And will I be able to get healthcare? And I think that's the kinds of things we need to address for the population.
Can it be fixed? The minister says, yes, he accepts what you're saying. I mean, he's sending doctors overseas, training.
So I think there's a massive second assumption, and that is the private sector has capacity to deliver healthcare services to the same quality in the private sector, maybe below, in that sector. And the answer is not that. We can build facilities like we built Stadia for 2010, no problem. Building people and building time is not the same. So just to give you some numbers again, South Africa has about 60 doctors per 100,000 population. This is published on WHO stats. Brazil has 189. Cuba has 672 per 100,000. We at 60 doctors. Specialists, we've got less than 25. When you look at OECD countries where we compare ourselves, as the government has, Turkey's got more than 100. The UK's got more than 180.
Okay, Lawrence, I'm going to play devil's advocate here. So the minister seems to acknowledge that problem. He seems to, so we're building a new medical school. The deans are coming on board for us to get new doctors. But I'll come back to that point. Roly, can I bring you in at this point in time? So when I read your profile, this sounded like Back to the Future for you. Okay, so you make this point that the kind of health systems that you were running when you first started your career in the mid-80s are what NHI is. Perhaps you can elaborate for the crowd?
Sure. I think, interestingly, when the government came into power, they took away the old Medical Schemes Act and replaced it with the current one that we have. And in the stroke of a pen, when the Prime Minister or the President signed it, he took away a whole system that was functioning very effectively in our country. It had a name called the Benefit Society system in this world. And I actually managed something called Valmed. It was a staff-modeled HMO, something that was run on the premises and the basis of Kaiser Permanente in the United States. At the time, our benefits compared better than the best medical aid that existed at the time, which was CMAS. It was the medical aid run by AMA. And our benefits were exceeded theirs in terms of medicine given, doctors' consults, hospitalization and everything, but at a premium of 40% discount. And it talks to an integrated model. It talks to a model where there's integration within a system. What we have in South Africa now is a system which has forced everyone. You talk about a hospital-centric model where the specialists are forced to come into the hospital because that's the legislative space that's been defined for us. Your colleague here spoke about the fact that the private sector has to make some changes. We can only make the changes within the space that we're given to work for a number of years. And I mean, I would hesitate to go back and put a date to it, but I think it must be 20 years now. The private sector has been trying to come up with a LIMS, a low-cost model. It is not impossible. It is done in the USA in the ACO models. It's done in Kaiser Permanente models. It's done in all sorts of other models. So it's very possible. And right now we have probably 4 million people that could be accommodated in that model in an integrated system which could work and which would produce some of the results. I just think that it's important that we realize that government should not be trying to fix all the ills in a financing system. They should be trying to create the regulatory space that people can play in, can be innovative in, and can make a difference. And I would also like to make one comment about the minister's statement. He talks about this WHO report, and I want to categorically reject the rubbish that's in that report. That report was presented at the HMI in one of the very first open sessions that was had. I don't know how many people came up. There must have been 5 or 6 alternative presentations. And at the end of that session, the HMI set out a notice saying that they will not place any reliance on that report. The reality today is that costing in healthcare is extremely difficult. There's a big study done in Europe where you have a model which is very similar to what the government is talking about now. You have a costing system that's very similar. You have a staff model gatekeeper system that's similar. And they set up a study. York University, the university in Spain, Berlin, Munich, and a whole lot of important universities that do health economics. And at the end of the study, they came up with the answer that it is impossible to compare the cost of an appendectomy in all of those countries unless you define it right down to specifics like age 18 to 27, no comorbidities, you must be running well, a marathon, etc., etc.
So there's a lot of controversy.
And so this rubbish where you make these big statements is really absolutely misleading. It's absolute nonsense.